Today let's discuss this topic of difficult airway management, which all of you all would have faced during your anesthesia practice. This is one of the most important topics, not just practically in anesthesia but also from the point of view of theory. Definitely there will be questions in it, as well as in your practical exam they will be asking you how to manage a case of difficult airway. My name is Dr.Jhanvi Bajaj and I have trained in MD anesthesiology from one of the major cancer hospitals in India, where we see difficult airway day in and day out in the form of oropharyngeal cancers. So let me give you a little bit of advice on how to manage difficult airway. Now, what is the definition of difficult airway? So, very simple. If there is a situation in which a conventionally trained anesthesiologist finds it difficult to mask ventilate, difficult to intubate, difficult to put in a LMA, laryngeal mask airway, or difficult front of neck access, any of these situations that arises, this is called as a difficult airway. There could be a combination of one or two of them. There could be difficult mask ventilation plus difficult intubation plus difficult supraglottic airway device insertion. So you need to define difficult airway based on any one of these parameters. On top of this, if you happen to have a difficult patient who is uncooperative, that can also arise into a situation of difficult airway. Now, there are two types of difficult airways. One is anticipated and one is unanticipated. Anticipated, let me give you an example. You have a patient with a large thyroid mass. You can see that the mass is compressing on the trachea. You can anticipate that this will be a difficult intubation, and you can keep in mind an airway management plan prior to the surgery starting. Unanticipated difficult airway, you get a normal patient. He says there is no history of any airway surgery, there are no symptoms. You look at all of his Mallampati classification, everything seems fine. You just go ahead with general anesthesia induction as usual, and then when you intubate the patient, you see that there is a CL grade of 4, Cormack-Lehan grade 4, not able to see the glottis and not able to put the tube. So that is an unanticipated difficult airway. For that too, we have guidelines in place which we will be discussing, and then we will be finally doing a case scenario where I will require help from you guys. So, before we begin, there are some predictors of difficult mask ventilation. There are a few mnemonics that are followed since time immemorial, and we will be discussing those. So, any patient who has a higher Mallampati classification, Mallampati 3 or 4, obese patients, old patients, age more than 55 years of age, because they tend to have this sagging area of the cheeks because of loss of fat. So the mask seal is not formed very well. In obese patients, the cheeks are so big that again the mask fits not perfectly, so you can have leak from the mask while ventilating. Patients with no teeth, edentulous patients, again when you are trying to hold the mask over their face, the mouth collapses inside, and as a result of this you are not able to ventilate. Last is snorers, again patients of OSA and patients who are having stiff lungs. In them you need higher pressures for ventilation, so that is a predictor of difficult mask ventilation. What are the predictors of difficult intubation? You have the Lemon criteria, very famous. Before, the L stands for look externally. Look at, are there any masses, or is there any edentulous, or is there any possibility that the patient is going to have a difficult intubation. E is for evaluate 3-3-2 rule. What is the 3-3-2 rule? The 3-3-2 rule says that the mouth opening should be more than 3 fingers. Now, when you ask the patient to open the mouth, and you are not supposed to put your own fingers, you are supposed to ask the patient to open the mouth and put his own fingers inside. Okay. Then you have the Mallampati classification. Then obese patients will have difficult intubation because of short neck, and also this area, that is the area of the chest, will abut against the laryngoscope. And finally, patients who have neck mobility issues. There is stiff neck, not much extension, not much flexion of the neck. These also classify in difficult intubation. Now in the evaluate 332 rule, the first thing was inter-incisor gap, which should be more than 3 fingers so that you can easily put in the laryngoscope. The next 3 is for hyomental distance, that is distance between the hyoid bone and the mentum. And the next 2 is for the thyrohyoid distance, the distance between the thyroid and the hyoid membrane. So all of these should be at least 3, 3 and 2 finger breadths. So this is your Lemon criteria which predicts difficult intubation in patients. What is the predictor of difficult supraglottic airway device insertion? That is given by the mnemonic rods. Now when you are putting in an LMA, remember it's quite big, so you might need some space to insert the LMA. So if the patient has a restricted mouth opening, inter-incisor gap is less, you will not be able to pass the LMA. Any obstruction in the airway, again the LMA will get stuck and it will not pass down. Any distortion of the airway, LMA will not go in without resistance, and you should not be forcing it inside because the placement will not be perfect, the patient will not get ventilated. And finally, stiff lungs. If the patient has stiff lungs, he requires higher pressure for ventilation, and in this case, if you ventilate through high pressures through an LMA, this LMA can get displaced. Okay, so you are ventilating, the LMA is placed perfectly, there is very high pressures of ventilation, this LMA may get displaced and the ventilation may stop. Finally, difficult predictors of difficult front of neck access. If you have to carry out a tracheostomy or an emergency cricothyroidotomy, in that case the mnemonic is given by SHORT. So S stands for previous surgery in the front of the neck, so there will be scarring which will make it difficult to find the cricothyroid membrane. Any hematoma in the front of the neck if the patient has had trauma or if he is post-operative. If the patient is obese, again it is difficult to palpate the thyroid and the hyoid and the cricoid and find the correct membrane. If the patient has received radiation to the front of the neck, these tissues become very thick and as a result of this difficult to palpate. And if there is any trauma to the front of the neck, again that is a difficult front of neck access. Now how do you evaluate the airway? First thing that you have to do is you need to have adequate mouth opening. What is this adequate mouth opening required for? You need space to insert your supraglottic airway device, you need space to insert your laryngoscope. How do we evaluate the adequate mouth opening? By checking the inter-incisor distance. Ask the patient to open his mouth wide. Between the upper and the lower incisors, ask him to put his fingers, and if this inter-incisor distance is more than 3 finger breadth, that means there is adequate mouth opening. Adequate space to push the tongue away. The tongue has to be pushed from the right to the left side while you are intubating. So how do you know whether this patient has adequate space to push the tongue away or no? You will check the thyromental and the sternomental distance. Now this is known as the Patil's test, thyromental distance, and sternomental distance is called as the Sava's test. The normal thyromental distance is more than 6.5 centimeter and the normal sternomental distance is more than 12.5 centimeter. How do you bring the oral, pharyngeal and laryngeal axis in one line? So to bring the oral, pharyngeal and laryngeal axis in one line, you need to position the patient correctly. And for this positioning, you should have good neck mobility. So you should be checking the patient's neck mobility, extension and flexion, and you should also be making sure that the patient does not have any associated cervical spine abnormalities which may make it difficult to give neck extension. Now, what are the ideal